Thank you to everyone who is joining today. We are so excited to have you here for our LNR hosted webinar with Brandy. Today, we're going to be talking about adapting clinical approaches for the continuum of care. So looking at some of Brandy's complex cases just from this calendar year already. So some very fresh new case studies that we're looking at. So with that, I'm going to hand it over to Brandy, and we hope that you guys enjoy this webinar.
Thank you very much, Lindsay, and thank you guys for having me here today. So I'm definitely excited about letting you all hear about some of my complex lymphedema case series studies that I am currently working on. So just to give you a little background about myself, I am the CEO and a certified instructor for ILWTI, the International Lymphedema and Wound Training Institute. I do love to travel around and speak at conventions. I am an honored member of several different boards, which I speak with and advise for. I have been a lymphedema therapist for 21 years. I've been an occupational therapist for 22 years of those 21 years, and primarily focusing in lymphedema practice. I am the director of multiple clinics in South Georgia that specialize in OTPT, lymphedema, and wound care. One of my favorite things to do is to consult with OTPT clinics, vein programs to help those institutions be able to build lymphedema clinics and programs that are nice and successful and definitely profitable. All right, so we are going to jump right into one of 4 case studies. So we're going to go over 4 complex case studies today. We're going to start out with a little bit of primary lymphedema first of all. So we have a male, 41 years old. He was diagnosed with primary lymphedema in his right leg at the age of 13. By the age of 15, he started to develop lymphedema in his left leg as well. And into his mid-20s, he was actually treated for the lymphedema, and he was taught self-bandaging. Since that time, this gentleman has self-bandaged himself every single day. Daytime, nighttime, all hours of the day. He came into me first for evaluation, bandaged. So he got into his mid-30s, and his lymphedema was primarily in the lower legs, but as it started to get a little bit worse and a little bit worse and a little bit worse. And so we started progressing into the upper legs, and then into the medial upper thigh region started to get more fibrotic and form into more lobes. As you can see right here, this is the date of our initial evaluation. So we have the ankle cuffs. We have some lobe formation right here at the top of the legs. You can see that you definitely have this cuff type effect right here in those lower legs. Very universal looking for a lot of our primary lymphedema patients. But now, mind you, this gentleman has been bandaging himself. This is not untreated lymphedema. He has been bandaging himself, but he just can't seem to quite get it under control. Therefore, we went ahead with this gentleman and started some lymphedema bandaging. We chose to be a little more aggressive with his bandage. Therefore, we chose to use a Crecia below knee bandaging liner. And then we used the short stretch bandages over the top of this. Of course, we still bandaged his toes. We actually used a lower and a upper leg Crecia for him so that we could bandage over the top of that. And then he could redo the upper leg as he needed to as well. I liked the Crecia because of the textures of that garment. So when you take that chip foam and you add it in there and you're constantly wrapping over that chip foam with that really fibrotic tissue that was built up in those lower legs, it really helped us to break that up quite nicely. We use the transelastic on his toes, put the Crecia over it, and then we went and used the multi-layer bandages, the short stretch bandages over the top of that. Being really aggressive with that bandaging technique because of the severe fibrosis in that lower leg and the fact that this is a really long-term chronic lymphedema. We had a lot to deal with here. So this is before the use of that bandaging technique. This is during the use of that technique. And then you can see here, this is after only 2 weeks of using that Caricia with the short stretch bandages over the top and the toe bandages. Quite impressive reduction here. This gentleman is a happy man at this point. And just by adapting our traditional bandage system, which he'd already been using, right? We just adapted it by using that Caricia. We were able to get some really significant results with this gentleman. Once we got him nice and reduced, we did decide that he was going to need a flat knit compression garment. Obviously, we don't want anything that's going to bind. That flat knit is ideal for a patient like this. And fortunately for him, he was on a very limited budget. We were able to use the off-the-shelf flat knit of the Exo Strong. This is a compression level of 20-30. He's able to don and doff these garments with absolutely no problem. We also used a capri with this gentleman to be able to help those upper legs. Once we really decongested this gentleman, used a lot of MLD, a lot of bandaging, using the Caricia for the upper leg as well, we were able to get some nice reduction of those lobes at the top of the leg as well. For nighttime, we decided that initially we were going to use the Caricia and let him just bandage over the top of that for evenings, for nighttime. But this poor guy had been really bandaging himself for the last 20 years, right? So let's make things a little bit simpler for him. So we decided to go with the Tribute Wrap for the bilateral lower legs. As you can see here, we're still using those capris for the upper legs, but the bilateral Tribute Wraps on the lower legs. So you've got the bilateral Tribute Wrap right here, and then we have the cover sleeves for those Tribute Wraps. That just makes it so that those straps, those Velcro straps, don't get hung in the sheets when they're sleeping at night. Primarily, there's not a whole lot of compression to these over sleeves as much as they are just for making sure that that it keeps them from catching. So we had actually brought this gentleman into the clinic. I put this on him for just an hour, right? Maybe not even quite an hour. And I took this off after that hour, and you can already see the wonderful indentations in the skin from some of those chips that are also in that Tribute Wrap. This gentleman definitely needs those chips in order to maintain this fibrosis reduction, to keep this nice and soft. So within just a short period of time, he's already got those indentations. You can see the channeling of that garment as well in this. So quite a nice garment for him for nighttime and for a maintenance program. Here's a little video of this gentleman donning the Tribute Wrap below knee garment. I really like to show how patients are able to do these kinds of things.
Here's a video on how to don the Tribute Wrap. First, we're going to take the top strap. I'm going to hook it on there just a little bit. And we're going to take the two small ankle straps. Hook it on ever so slightly. Ever so slightly. And now the patient is going to pull that up on the leg so that it holds it all in place. Now, once he gets that pulled up on the leg, then he's going to come back and he's going to adjust the ankle straps.
As you can see, this is pretty easy for him to don.
Come back, tighten that top strap up a little bit. Now he can come back and adjust all the rest of the straps.
And compared to the multi-layer bandaging that he was doing to himself, this cut the time in at least half, if not maybe even a third of the time that he was spending to be able to self-bandage himself every evening and every morning.
We have a little gap right there in the middle, so let's adjust those other straps just a little bit. Perfect. Now he is going to put the oversleeve over the top of that garment.
And if you notice that oversleeve does have a little slit feature on the bottom, so that if that patient does get up at night, then they're not going to fall as well. And it does add a little bit of compression over the top of that as well. So just a little bit more compression makes it a little bit more aggressive for this patient as well. All right, so this gentleman, we asked him to give us his experience, right? So he had been wrapping his legs for such a long time with those short stretch bandages. It took him a lot of time, and he was getting really frustrated because he wasn't getting the good reductions like he did initially. So we took him, used the Crecia with the short stretch bandages to get those legs nice and reduced. And then we decided to make it as easy as possible. We used that tribute wrap with him. He was ecstatic with that. As he said, it was a game changer for me because he was able to get it on and off. And then he had nice reductions when he took it off. He didn't have that lobe formation still forming, and sometimes kind of little areas that would pooch out because that bandage wasn't just right with him applying it. So the tribute wrap has made all the difference in maintaining those reductions for him, as well as those flat knit compression garments during the day. All right, we're going to move on to case number 2. Now, this is a very extensive case. Forewarning, just a little bit before we get to the pictures with this one. This patient is still in treatment with me, but in the latter stages. So this is metastatic breast cancer with stage 2 lymphedema of the left upper extremity. She's 71 years old. And just forewarning that when the patient came in for initial evaluation, she had only been seen by the surgeon the day before, and there was not actually a formal diagnosis of her cancer, not by biopsy proven at least, okay? She had not seen the oncologist. The symptoms that we initially saw was a large fungating tumor of the left breast, moderate stage 2 lymphedema of the left arm and chest region, and she'd already experienced 2 different bouts of cellulitis in the left arm prior to the diagnosis or anybody even saying that it was remotely breast cancer. This patient did know that something was significantly wrong, and she had just not sought treatment. She was kind of hiding it. So that's how we ended up here. Definitely the largest fungating tumor of a breast that I have seen in my 21 years as a lymphedema therapist. So she was initially seen by that surgeon, the breast cancer surgeon, on March the 27th. By March the 28th, he had already sent her to me, making sure that we could go ahead and take care of the wound from this fungating tumor, and also take care of the significant lymphedema that she had in her left upper extremity, which was causing recurrent cellulitis. So the left upper extremity at this point is 81% larger than the right arm. The left breast is a large fungating tumor. There are definitely palpable nodules at the cap of the shoulder, bilateral supraclavicular node regions, and also in the right axilla. The patient was still awaiting further testing. Obviously, we still had not had the biopsy back. You can see right here where this is where they took the biopsy from, was this little area right above that little yellow slough area. And she still had to meet with oncology at this point. So the treatments in our clinic from day 1 started with gentle debridement. She was very tender at first. This fungating tumor was very sensitive, very painful. It also, if you have ever experienced any patients who have had cancer that has come through the skin, so causing any type of fungating tumors, the odor of that is a very pungent smell, very difficult for a patient to tolerate and want to go into public with. Therefore, it was absolutely necessary that we used an odor control dressing, and then we were using a foam dressing for management of the moderate exudate with her as well. For that left upper extremity, we used a multi-layer bandaging system. Debridement with her, there again, in the initial stages it was quite painful, even with the use of Debrasoft. So this is a few weeks into treatment, just when she was a little bit more tolerable of the actual debridement itself. But we're using the Debrasoft
to debride some of this fungating tumor so that we can clean it up. As you can see, this is a really painful breast, but this does not bother her at all.
Not at this point.
It's extremely soft, doesn't seem to bother her much. You can kind of.
Okay, so what's happening is she's got some hyperkeratosis built up on this breast as well, where the scales from that fungating tumor, we had removed all of that primarily with forceps and just getting all of that part off, and then using the Deborah to gently debride the rest of that tissue until we got down to nice healthy granulation. And then by this point we're debriding off some of that hyperkeratosis, making sure that none of that builds back up to be that really scaly, thick crust that causes wounds that form underneath it. So the carbon cloth dressing is an absolute must for patients who have a fungating tumor. So it's just a carbon dressing. We put that on and immediately the smell is controlled. So this patient went from not wanting to really be around anyone, didn't want to go out much, didn't want to do hardly anything, because as soon as the fungating tumor would drain onto any kind of dressing, she was using ABD pads and things like that when she first came in. The odor was quite significant. And so she was kind of turning into a more reclusive type mode because she didn't want to be around anybody to figure out what was going on. So we used Zorflex. Zorflex completely stopped that odor. Didn't have any problems with that from that point on. This was a happy lady. She actually started going back out, would go out there, get around people more, much different. We used the Superzorb P on this patient primarily because we needed something for the management of a moderate exudate, especially initially. But the other thing is this was very comfortable for her. So she still wanted to continue to wear her bra, and the Superzorb P was nice and soft. Didn't feel like any edges were going to poke into her or anything along that line, nor did it stick to any of those open wounds, which was quite nice for her. So the use of the Zorflex with the Superzorb P was huge in our wound management. So chemotherapy with this patient obviously was an absolute must. So patient started FEC for 3 rounds. She started that on April the 20th and ended on June the 23rd. Then she started the use of doxycycline for 3 rounds, and that started on July the 6th, and she actually ends that tomorrow is her last round of that chemotherapy. She's quite low right now. She's had to have fluids on several different occasions, but it is working beautifully. As you can see from these pictures, this is April the 28th. This is prior to any kind of chemotherapy. We've already started cleaning up this wound. You can see things are starting to heal. The scales and the crust we are starting to get off of there, but nice and slow and easy. She's quite painful. They're here on May the 2nd. She's already had a treatment of chemotherapy, and you can already start to see that this is starting to reduce quite nicely in size, as well as we're getting everything nice and cleaned up with this wound as well. So the debridement is working quite nicely, nice and slow and easy. By May the 17th, we have a complete turnaround. The tumor has shrunk quite extensively, even just from that first little bit of chemotherapy. And we now have been able, because the pain associated with that tumor, because when it started to shrink, we could then debride that more extensively to be able to get that all cleared up. As you can see, by June the 14th, we even start to see some nipple formation come back out. The doctors didn't think that we were going to find any of that, so that was quite impressive. And you can see that large tumor that was almost on top of the breast itself that has started to shrink quite nicely as well. By July the 5th, there again, some of that redness is starting to go away, and this continues to shrink significantly. If you notice here, from June the 14th to August the 9th, we haven't put in any compression on her breast, but we have done extensive MLD surrounding this area. She also has a large scar from a cabbage that was 2 years prior to this diagnosis. So we haven't really been able to take anything across her chest, but we've used the posterior side of her body, going to the contralateral axillary nodes, and then as well as the ipsilateral inguinal nodes with this patient as well, with nice reductions around this breast as well, with just the MLD right there. We used a multi-layer short stretch bandaging system on this patient. So we used Transless Classic on her fingers. And then because she was just a really sensitive patient, this patient had been through 2 rounds of cellulitis quite recently. The arm was quite painful. So we decided to use a CLT-LANA primarily on her hand and then up her forearm with a lot of padding right there at the elbow, the bend of the elbow, so that we wouldn't get any friction right there. We then used the Rosidol Soft to add a little bit extra compression, but also to help us keep these bandages up. And then used a 4 centimeter, 6 centimeter, 8 centimeter, and a 10 centimeter bandage, short stretch bandage on her arm. She reduced beautifully well once we started this treatment with the multi-layer bandages. As you can see here, the patient has now received 5 rounds of chemotherapy with a great reduction in the tumor size. And then that upper extremity, that left upper extremity, has now reduced to within 3.4% of the right upper extremity. So she has full functional use of that left upper extremity, or a light functional use. And then we were able to fit this patient with short stretch off the shelf garments. So with the extra strong glove and arm sleeve. And then for nighttime, this patient is also using a tribute wrap from the MCPs to the axilla with this patient. This patient is a Medicare patient, therefore we tried to utilize garments that were going to be a little more cost effective for her. Obviously, she still had quite a bit of out-of-pocket expense, but not quite as much as if we had used some custom compression garments. Luckily, she did reduce to a size that we could fit quite easily into an off-the-shelf. So here is that flat knit glove and arm sleeve for this patient. This is 20 to 30 millimeters of mercury pressure. She can don and doff this compression sleeve all on her own. She does have a sister that likes to help her out a pretty good bit, but still she can do it by herself if she needs to. The nighttime garment, she absolutely loves it. She says it's nice and comfortable. And just so long as I won't bandage her anymore, she'll wear it every single night. So you can see from this tribute wrap that we have the impressions from some of the chip foam that is in that tribute wrap, as well as the channeling from that tribute wrap on her forearm. I asked her to take this picture at home for me. She's done quite nicely with her home management program. We're now only seeing her about every week to 2 weeks, just to be sure that we get through all of our chemotherapy with that arm staying nice and reduced. The fibrosis in the forearm does tend to want to come back just a little bit. But with a little bit of extensive MLD in the clinic, we were able to reduce that as well. The patient will get this. She will have the last chemotherapy tomorrow, and then approximately 4 weeks after that, she will have a bilateral mastectomy. And we'll continue to treat her after that as well. All right, so let me go on to our third case. So this case is a very extensive case as well. And you can see how this gentleman has been in our clinic for the last 4 years. He's had chronic longstanding lymphedema for 5 or greater years, multiple bouts of cellulitis, weeping, wounds, has ended up in the hospital on multiple times with the cellulitis on IV antibiotics. He is a partially retired farmer, and he has an amazing family support system, which has been extremely helpful for us. So for the last 2 years, he's been on what we call our maintenance program, which means that we still like to keep our eyes on him because he's one of our high-risk patients, right? So we are only seeing him 1 time a month for the last probably over a year now. So the patient was seen in our office on June the 28th of 2022. He comes in, he looks great. He's well controlled at home. He's got a FlexiTouch advanced pneumatic compression device. He's only wearing 30 to 40 circular knit knee highs at this point. His legs are beautifully reduced. Sometimes he's wearing thigh highs. He's got compression shorts, exercise, and he's been quite faithful with his home program so that he doesn't have to be bandaged anymore. However, accidentally, on June the 29th, this gentleman was getting off of a bulldozer and he bumped his right leg on the gear shift. Didn't really think anything about it. He arrives home shortly thereafter, and the leg started to get a little bit painful. He removed his knee high and found a hematoma on the leg, on the anterior surface of the right lower leg. Over the next several hours, that hematoma got larger and larger and larger. Eventually, that patient had to be taken to the ER. The family was actually texting one of my staff therapists, who's an amazing therapist who's been treating him for the majority of the period of time in our clinic. And she and I also helped to encourage them to go to the ER. Past medical history, this patient is on Xarelto for AFib. That Xarelto is probably what caused this. Okay, so this is within 1 hour of that injury. Now, mind you, he didn't hit it so hard that he thought, oh gosh, I broke my leg. No, it was not that kind of bump. He bumped his leg. Obviously, he must have hit a vessel, right? And we bled out into the tissues. Upon presentation at the ER 5 hours following, we have this presentation. Quite extensive hematoma in this leg. Cellulitis is already starting to light up quite extensively as well, because he has cellulitis recurrence that is super easy. By the time he goes to the OR the next morning for a fasciotomy and IND, this is what that extremity looked like. So this is 2 days post that initial fasciotomy with IND. They did remove a football-sized hematoma from his lower leg. So you can note the significant discoloration, bruising. This is really necrosis of these tissues around this wound. And you'll see more of that in just a little bit. The patient by this point is definitely on IV antibiotics, but he is beginning to swell in all 4 extremities at this point into his abdomen and genital region. He did have another IND on day number 2 of the hospital, on day number 4 of the hospitalization. And on day number 5, he was finally started on some IV Lasix to start trying to get this fluid out. And that was done primarily by his cardiologist. He was discharged home on 7/11 with orders to return to our clinic for lymphedema and wound management. The patient chose at that point not to go to a standard wound care clinic, very simply because he knew he had extensive lymphedema problems, and that without the management of the lymphedema, the wound was not going to heal very, very rapidly. So this is day 1 of treatment in our clinic. I didn't exactly know what I was going to unbandage when he first came in. And as you can see, this wound is quite extensive. The lymphedema in the leg is quite extensive. We have a lot of necrotic tissue. We have a lot of tissue that is not healthy, not getting good vascularity. Down here on the side of his leg, this tissue is not healthy tissue. So over the next several days, we were seeing him daily. At this point, the exudate was copious amounts of fluid, lymph fluid. And so this bandage had to be changed daily. We were doing wound care daily in order to get this cleaned up and get to a manageable point. For dressings, we were using the Superzorb P, also using the ABD pads over the top of the Superzorb P just to catch any extra exudate as well. The Superzorb P, that it was extremely painful at this point. The tissues had expanded so much that it was just super tight, super painful. The wound was painful. The Superzorb P being the softest I could possibly think to use for him, and also manage that high level of exudate at this point. We decided with this patient to use a disposable multi-layer system, so a 2-layer system. So we decided to go with the Rosidol TCS system. We were using 2 of these. So we were using one for the lower leg, one for the upper leg, with the most important pieces of this being that we really needed the soft layer over the wound dressings so that he could tolerate it. He was quite painful during the majority of the initial phase of this treatment. And then being able to use the short stretch CC cohesive layer over the top of that, and then using that all the way to the very top of his leg. As you can see here, this is when we were actually putting those dressings on and using that TCS system.
We're going to be dressing this with Superzorb P. We need multiples of these. And also, we will be putting the Rosidol TCS over this. The TCS is a soft layer to add a little cushion to our 2-layer system. And it works exceptionally well with patients who have lymphedema and wounds, because you can turn around and
throw it away.
And in a sanitary fashion, you can also bandage that leg. So that's our soft layer. And next we got the compressive layer for the TCS.
The beautiful part about these
compressive layer starting right here at the base of the toes.
dual layer systems is that
around.
if you are using a company like Prism or Halo, they will actually pay for these dressings if the order is written by the physician for these dressings.
Get on it. It actually comes off of the roll in a compressive state.
So that's full stretch when that comes off of the roll, adding your short stretch compression over that. And you can see how easy this is to apply.
When we get done with this, we're actually just going to cut it off. And roll away this wrap. And we start over with a new one on the next go round. We're also, because he has full leg lymphedema, we're actually going to use a second Rosidol TCS for the top of the leg as well.
All right. So as you can see, this is progression by July the 21st. We've been using the 2-layer system along with our wound care, along with sharp debridement, obviously, for a lot of that necrotic tissue, including scissors and forceps. And then we get to this point right here. We've got a lot of the necrotic tissue gone. The patient at this point has been seen 8 out of the last 10 days. Now, mind you, we started this on July the 12th. This is only July the 21st. All of that necrosis is gone. Now we're down to a rather bumpy granulation, right? It's not real smooth, not real consistent. There's still some deep areas. There's a large tunnel in this area right here that goes down almost 5 centimeters down into this area right here. So we've actually been packing that with gauze. We've been dressing this with Anacept gel, which is antimicrobial to try to keep all that bacteria at bay, using the Supersorb foam, and then using the ABD pads as we needed them. So by the time we got to this point right here, we could start to use a little bit different debridement methods, still using a little bit of forceps and scissors as needed, but we could start using something that was a little bit more meant to get rid of that yellow slough, create that nice red granulation bed.
And now we're going to use Deborah-Soft to debride this wound. We have the soft side of the Deborah-Soft. There's the back side of it. We don't use that side. We're going to use this side. I'm going to wet this with just a little bit of wound wash.
Deborah-Soft can also be wet with water. You do not have to have a wound wash. I just use the Anacept spray because of the antimicrobial effect for him.
Rub in circles over this wound. You see all the yellow slough. It's going to clean this up really, really well. And we can use this one Deborah-Soft on this one wound, because it's all one wound. If this was multiple wounds, we'd have to use a different one for each section.
As you can see, that just starts to get that yellow slough right off of there. It's quite impressive, and it's not hurting him at all. He is not painful at all, even when I get on those wound edges. Whereas it seems like when I pick up the forceps and I start to pick at those wound edges, he'll usually kind of jump a little bit with me. So that Deborah soft, he absolutely loved once we got to this part where we just had the yellow slough primarily remaining. As you can see, he did start to bleed a little bit. Blood is good. I tell all of my patients that it's okay. Plus, he's still on a blood thinner. He's going to bleed just a little bit more than a patient who's not on a blood thinner as well. A little bit of added compression with that, and that bleeding stops instantly. So this is yesterday. So I went ahead and took some wonderful pictures yesterday after we got him nice and cleaned up. And as you can see, it's the same exact treatment methods. We haven't changed anything, okay? The patient did have to be treated for Pseudomonas just last week because the drainage started to get a little more copious and green. And if you ever have smelled Pseudomonas, it's a little bit of a sweet smell with that as well. We've also been having to do a lot of MLD with this gentleman as we've had a lot of abdominal and genital edema with this gentleman as well. And the more MLD we would get to do with him, the more this leg healed, the more this leg started to drop with the lymphedema. You can see that all of this tissue has healed over quite nicely. You see these little epithelial islands all forming in here quite well. Down here was actually a giant flap of skin that I was quite concerned that wasn't going to tack back down. It tacked down quite nicely, started to heal in. And as you can see, we've got wonderful wound edges all along this wound. The tunnel is still about 3 centimeters right here, but still filling in and going to fill in eventually quite nicely with no problems. So this is what we have decided to do with this gentleman to make it so that if we can't get to him, he can still change the dressing at home, or he and his family can change the dressing at home, and they still have some compression on this leg. The compression is an absolute must, as the gold standard for wound healing is compression. So whether that be a Rosidol TCS or a Ready Wrap, we need compression on this gentleman. We're not able to pull a compression garment over the top of those wounds dressings just yet. But what we can do is we can use the Ready Wrap liner, which is real stretchy, right? I can pull that up and over our wound dressings. And then I'm able to put the Ready Wrap calf. And then for him, we need the Ready Wrap thigh, the Ready Wrap knee, and then the Ready Wrap foot CT. And I'm really liking this new foot CT because it covers the entire foot and has 3 different straps on that to get really nice compression on that foot. And the wonderful thing is we still got this gentleman's foot into his regular tennis shoe, even with all of this Ready Wrap on here. So what I have actually done is what I'm going to do for this upcoming weekend is we're actually going to wrap him in the Rosidol TCS to the knee. And then I'm going to take and put the thigh and the knee piece on this so that he can get in the shower for the first time since this whole thing actually started. He's actually going to use just a shower cover up to the knee and then go ahead and get in the shower with this as well. We've been actually having to wrap the other leg as well. He's had some cellulitis in that leg that landed him in the hospital for a few days as well. And then having some issues with genital lymphedema. However, all of that has quite nicely resolved. And thank you to my staff very much for assisting with all of the wonderful MLD while I was doing a lot of the wound care and lymphedema management in the lower extremities. So I have a wonderful staff who comes in anytime that they can and does a lot of more proximal MLD for me so that we can get him nice and opened up. Our last case of today is we're going to take it to some cute stuff, right? So we're going to take it to the pediatric primary lymphedema patient. And this is a little cutie girl. She's 6 months old now, or was in these pictures. And she has Turner syndrome. So I know a lot of patients, I know a lot of therapists go, oh no, pediatrics, I'm not so sure I can do that. But remember that all of the techniques that we use for adult lymphedema treatment, they apply to pediatrics, okay? And more than anything, we need to get these patients into treatment as soon as we possibly can so that they get used to the compression. They get used to what the treatment feels like so that it becomes part of their normal daily routines as they grow up, because this isn't going to go anywhere, right? We saw that with our first primary lymphedema patient, that he started when he was 13, probably had it prior to that, probably something very similar to this. However, nobody picked up on it. All right. So the sooner that we start, the more easily it is going to be to just keep her in that compression throughout her lifetime. So at 4 months of age with Turner syndrome, a lot of these children do have heart conditions. And she did have open heart surgery. So it was not until 6 months of age that we began the lymphedema treatment. And we started that at 3 times a week, kind of dropped it back to 2 times a week once we got things going a little bit. As you can see, she has these little ski jump nails. Those are very common with primary lymphedema at infancy. And they're very susceptible to ingrown toenails. So you need to be aware of that. So this patient is actually being followed by a podiatrist as well. So he kind of helps us to cut some of these little ingrown toenails out to make sure that doesn't become an issue. But that's also something that you need to think about when we're using compression garments, to make sure that we don't have too much compression around those toes that it's going to create any more force that might cause some ingrown toenails as well. So there's a happy medium there, right? We need the compression for the toes, but we don't want to cause those ingrown toenails as well. So this is how we treated this patient. We treated her for 3 times a week. I treated her for 45 minutes to an hour sessions. We did a lot of baby massages, is what her mom and I called them, and to promote MLD throughout her little body. We did a lot of passive range of motion, ankles, knees, hips. And then what we did was bandaged her for nighttime with these, she had binky boots, and then we used the Rosidol K short stretch bandages over the top of that. And I taught her parents how to do all of this, right? Because this is an ongoing process. They're going to need to do this for her entire infancy, childhood, for her until she's able to start to take this over. So they were able to bandage her over those binky boots. Binky boots have a little bit of that chip foam in them as well. It breaks up some of that little fibrosis as you see on the top of her foot and on her toes. Mom and dad became very proficient with MLD, even made up a little song that we would sing to her while we were doing this. So here is her daytime garment. So LNR has a program called Early Impressions, as well as several of the other companies, compression garment companies, have early infant or child programs. So LNR's program is called Early Impressions. And what they do is they will fabricate, these are little tribute, instead of nighttime garments, these are daytime garments. So they're little boots, they're little tribute boots. And so these can be replaced from the age of 0 to 4 up to 2 times a year. So these are little covers for those boots so that the little Velcro straps don't come off of them. But a lot of time during the day, the parents would actually just let her wear these little boots without the little covers even on them because they were really cute. And then as she was sleeping and stuff like that, we would put the little covers, or if she was moving too much and started to unvelcro them. And as she started to unvelcro them, we would put the little covers over them as well. She tolerated those garments beautifully well during the day. It's not, you cannot put a standard flat knit or circular knit compression garment on an infant. You will never get it on, okay? Once they get a little bit older in age, I've put up to as early as about 2 years old into more standard compression garments, custom compression garments with flat knit. But until that age, it's very, very difficult to try to get much on them. These little tribute daytime garments are extremely easy to don and to doff. The parents liked them. The child seemed very happy in them. It actually gave her something to play with. And the best part is that this mother had been caring for her daughter for this entire ongoing months because of her child being sick with needing open heart surgery. And so she'd not been working. And so to be able to financially not be responsible for those kind of garments was a really, really large deal to them. And they were extremely grateful for this Early Impressions program. All right, last but not least, one of my missions in the world of lymphedema is to make sure that all of our coding is correct, because what we know about ICD-10 codes is that they are tracked by the World Health Organization. And so the incidence of lymphedema is often dictated by the coding that we use and the codings that are implemented in our systems for treatment. So if we are not using the correct codes, say we're using R60.0, which is edema, instead of using lymphedema, then that's what the World Health Organization tracks, right? So we need a standard system for our coding as we can possibly get. There are only 3 codes for lymphedema. When you are treating lymphedema, one of the 3 of these codes always needs to be in use. So for primary lymphedema, remember that's at any age. That's congenital. That's that infancy to 2 years old. That's that precox lymphedema that we often see around that puberty type age, or when we saw that first primary lymphedema patient case. And then once we get older, you can even call it a lymphedema tarda. Primary lymphedema tarda is after the age of 35. So there's a whole gamut of patients that have primary lymphedema and get diagnosed with primary lymphedema at different stages in life. So the other cases that we have is post-mastectomy lymphedema syndrome, I-97.2. Now, this includes all of your partial mastectomies, your lumpectomies, which is actually not coded as a lumpectomy anymore. That is now called a partial mastectomy. Although you will see it written out all over the place as a lumpectomy still, but that is still considered a mastectomy, a partial mastectomy. Therefore, it very easily falls under this post-mastectomy lymphedema syndrome. However, that second case that you all saw me present with the fungating tumor, that case actually falls under an I-89.0 lymphedema acquired, because that patient is not post-mastectomy, right? She will be, and I will change the code once she has had her mastectomy for the lymphedema in her arm. However, because she had not had surgery, I could not use that code just yet. But I can use I-89.0, which is other lymphedema acquired. Now, just note that that is acquired, which means that something else caused it, right? So make sure that when we use this code, that we do back up this code with a supporting code. What did cause it? Was it venous insufficiency? Was it breast cancer? Was it a knee replacement? Was it a traumatic event? The list goes on and on and on about things that can cause lymphedema to be triggered and initiated. So just make sure that when we're billing for our lymphedema treatments, that we're using the I-89.0, the I-97.2, or the Q82.0. The World Health Organization does keep track of this. It's not just for your reimbursement purposes. Although when you are billing for lymphedema treatments, if you want to get the best absolute reimbursement and the best number of visits out of that patient, it is going to be substantially more when you're starting to use a code such as lymphedema versus edema. Okay. I appreciate all of you listening to me today. I'm definitely up for any questions, and I have stayed right on time. So proud of myself. And thank you guys so much for L&R letting me present this presentation to you all and sponsoring us today. The webinar you can find on the recording on this little link right here. And then please, any questions that you have from L&R, you may email them or look them up as well. My email is Brandy McKeown at ILWTI.com. And you can also look us up on www.ilwti.com as well for more information. Any questions?
Thank you, Brandy. And I know that Brandy shared that link. The webinar recording will be available in the next week or so at that link. So keep an eye out for that. So we're going to jump into the questions. Right now, we've got 12 open questions. We've answered a couple just via typing them over the last 45 minutes here. So let's get started. What kind of capri did you use for the first patient?
So that was a Sigvaris capri. The Comfort Shorts. Yes, the Comfort Shorts capri. By the time we did the MLD, he was reducing beautifully well up there. Didn't need a lot of compression up there. Had we needed more, we would have had to gone with a custom Capri.
Perfect. Thank you. How do you know when you can wrap with active cancer?
Okay, so active cancer, what we know is that with lymphedema treatments, we are not going to move active cancer. Okay. It is okay to wrap over nodules. It is okay to wrap an extremity that has active cancer. You are not going to move that cancer. We know that through much research done with MLD. I don't necessarily massage directly over that fungating tumor, but I massage everything else around that area. So my MLD went over those little nodules. It's okay. I am not going to move that cancer. Not to mention that that patient was also on active treatment for that cancer. And you could watch the tumor shrinking as we were doing it. But it is okay to treat an active cancer patient. Please never hesitate to treat those patients.
Thank you, Brandy. So another question, and this is related to the first gentleman in case study 1, but also, in general, how do you get this gentleman or other gentlemen and women like this to be able to wrap on a limited income to get those Carecia garments, tribute wraps, and those other supplies needed?
So, when we come in with a patient like that, sometimes we have donated garments in our office. Sometimes when I do the evaluation, we start talking about the cost of things right up front. So this man had some bandages all on his own already. So we were able to purchase the Carecia garment. We started early off talking about the Carecia and then even into the tribute wraps and what the cost of that was going to be versus something custom. He was able to financially afford those compression garments. It did take him a little bit of time to save up some of that money. But now this gentleman also realized that he had a significant problem and he'd been treating himself for quite some time. So he was very willing to come out of pocket with some of that. Couldn't go extreme with the cost of that, but because he knew how important it was, he was able to come out of pocket with some of that as well.
Thanks, Brandy. So someone anonymously just posted, this is a remarkable improvement in case study scenario 2. So great work. Next one from Jillian. I thought MLD was contraindicated with active cancer diagnosis. At what point did the MLD begin as compared to the wound care and chemo? So a little bit of what you covered, but maybe anything additional there.
So the MLD actually started from the first week. We actually started a little bit of MLD prior to her starting her chemotherapy. I started across her back. There was no active cancer that I could feel across her back. I stayed away from the active cancer areas more because it was more painful than anything. But what we know there again is that when we do MLD across those nodules, we're not doing any deep tissue, right? We're not trying to break up those nodules. We're very simply using that more superficial lymphatic system to try to get that fluid to move. You are not going to move that cancer. There is no research that shows that our MLD techniques nor our bandaging techniques are going to move that cancer. As a matter of fact, there are studies that show the exact opposite of that.
Thank you, Brandy.
And it was for a long time that you're right, that exactly was the thinking, that we could not do MLD over active cancer and we could not bandage those active cancer patients. But a lot of that has changed in the last few years.
Thank you. So Laura had asked, what all do you use to monitor the patient's progress?
So we use, I actually use the Lymphotex scanner for volumetric measurements, as well as a plain Jane measuring tape, right? And then for our wound measurements, it's just a measuring tape for those as well. Some Q-tips, some of the sterile Q-tips for the depth.
Laura also asked, when you see a patient for maintenance, do they pay out of pocket for these garments?
So,
Or sorry, I apologize, not for these garments, for the maintenance treatment.
no, so they do not use those for, they do not pay for the maintenance treatment. So Medicare actually does have a little stipulation in there that you can treat a patient for, that you can treat a patient on a maintenance plan. You just have to make sure that your plan of care is set up very specifically to state that. It is
Thank
allowed.
you. Tracy asked, when seeing patients for longer standing 1 times a month checkup, do you bill for that? If so, any insurance issues? So same thing.
No insurance issues. And just a little update on that as well. I get Medicare audited in my office. Therefore, I get audited about every 4 to 6 years. 4 to 6 years. I was audited 2 months ago, and I always make sure that I pull one of those maintenance patient charts for him to go over, to be sure that we don't have any issues with that. But I have not had, I did have to kind of prove my point when I first started doing it, but I've done it for so long now that I don't really have any issues with that at all.
Thank you. Did you wait for debridement of the necrotic tissue in the lower leg before beginning treatment on this patient? So for that 3rd case.
I did the debridement of that patient. So no, I did all of it. I know most people think that that was surgical. It was not. I did it in office.
And did you wait for the debridement of the necrotic tissue or anything with that in regard to that necrotic?
No, I debrided all of the necrotic tissue on that patient. So I slowly debrided that over a series of days. The patient did not have any, beside the wound edges, a lot of that was, he didn't have any sensation to that tissue. And so it was very easy to cut that tissue away. All I used was forceps and scissors with that patient from a debridement kit.
Thank you. So is there still not separate codes for lymphedema, correct?
Not codes for lymphedema, no, unfortunately. We're working on that.
Is there a handout for these codes? Just to keep in mind too, we do have the webinar recording where you'll be able to go back and fast forward to that part of the slides.
Right.
And so you will be able to see it there, but anything else there?
They can definitely email me and I will be more than happy to send those codes over.
Thank you. A comment, great lecture from Pamela. Next one, do you know any financial help available for patients in an SNF setting?
You know, not a whole lot. However, if I do know of some SNFs who will purchase compression garments for patients. So kind of look into that, see if they can somehow get some reimbursement for some of those. I have had some therapists tell me that they can. Some say that they have a harder time. I think it really just depends on the SNF that you're in, and then what region you're in as well when that stuff is billed through. Yeah, and then mostly if you reach out to more local community type resources, you're bound to find more assistance for those SNF patients as well. Maybe even some local churches or community organizations.
Thank you. Jason had said, congratulations for a great presentation. For the 3rd patient with a tractor injury, would you consider negative pressure wound therapy plus MLD?
So I absolutely thought about it. Definitely thought about it. However, I was going to have a harder time trying to get the necessary compression bandaging over the top of that. So that's where things went a little bit tricky. So I had not ruled it out at all. If the wound had not healed so quickly and continued to heal so quickly, I definitely would have gone with a wound vac on that patient once I had gotten the lymphedema reduced quite nicely. Yeah.
Now, next one, do you think axillary web syndrome can cause lymphedema?
I think that my thought process on that is that I think that patients who get axillary web syndrome do tend to have a higher incidence of developing lymphedema. I cannot say that it causes it.
Thank you. Erica had asked, what guidelines do you use with cellulitis in terms of MLD and compression wrapping?
So I like for my patients to have been on antibiotics for 48 hours before I start putting compression bandages back on them, and they have to show some symptoms of resolve. Even if it's still warm, hot, I'll go ahead and add compression back to that, do MLD more proximal to that region, just so long as we're on active treatment and we're showing some signs of improvement.
Thank you. What is the best way to get rid of severe hyperkeratosis without wounds? Do you have a topical product to soften, or could you use the DebraSoft even without a wound?
So you can definitely use the DebraSoft even without a wound. And I do like more of the petroleum-based type ointments, such as Aquaphor, stuff like that. So sometimes what I'll do is I will go in and put a bunch of that Aquaphor on a leg, let it sit for, especially if I'm doing MLD on the other leg or MLD more proximally, and then I'll come back and I'll wash that off, and then I'll come back with my DebraSoft over the top of that. Oh, it works beautifully.
Thank you. Teresa had said, thank you for your time and knowledge. We've got, is chemotherapy and bandage go simultaneously, or can chemotherapy and bandaging go simultaneously? I think is what they meant.
Absolutely. No contraindications there whatsoever.
All right. I have many breast lymphedema with Purity Orange, and I treat with MLD and compression wear bra, swell spots, kinesio taping. Many older women don't want to wear swell spots because of appearance. Any thoughts?
Nighttime, use them for nighttime. So put that patient in that bra, use the swell spots at night. The other thing that you can do is that you can still use a little bit of compression in there. So you can try some thinner grade foam in those bras that's not quite as thick as a swell spot. And another thing that a lot of my patients like is that sometimes I will even take like a incontinence pad or a Kotex pad, and I'll use it as compression in there, and that way they can throw it away and change it. With sweat that gets on that, it's a little bit more hygienic for them as well. I know that you can still wash the swell spots, you can still wash the gray foam, but sometimes they like that they can just throw away, and then use the swell spots more at night or when they're at home, and that way it's not quite so bulky when they're out during the day.
Awesome. I am a PN student. This has been highly informative. Thank you, Brandy. How soon can you return to MLD following cellulitis?
So about 48 hours, just the lung. I think we already covered that one pretty well. So.
Can you get handouts for this course? We will have the webinar recording, but at this time we will not have any printed slides.
Sorry.
What are your what were your guidelines for starting treatment post-cardiac repair?
So post-cardiac repair, that really has a lot to do with a cardiologist, because some cardiologists say that you have to wait at least a month before we start to do too much MLD, pushing fluid around, that kind of thing. And then some of them are more along the lines of get rid of the swelling so that it doesn't affect our repair. So really it's going to be based from the cardiologist and what kind of repair was done, how extensive it was, all of that kind of stuff. It's kind of hard to have a little bit of a guideline with that.
All right, thank you. Does Medicare cover DebraSoft?
Not most of the time. Sometimes I am able to get it when I'm ordering wound care supplies. I sometimes can get it if I'm ordering very specific stuff for larger wounds. Yes, but a lot of times not necessarily.
Thanks. And this is a little bit with DebraSoft, but with the other wound care products as well. Do you use any procedure codes for wound care, wound dressings, and debridement?
So when I am using debridement codes, so I'm using like the 97597 for the for the more sharp debridements, more extensive debridements, 97598, which is greater than 20 centimeters. So you can use the 97597 and the 97598. And then you can also use, if I'm using like the DebraSoft, there is a code that is for a non-selective debridement as well. And I'm using those codes. I'm not actually billing for the supplies themselves because I am an occupational therapist and we don't get any reimbursement for that type of stuff. So I have the physician order it directly for that patient. A lot of time I'm filling out that order form, sending it to the physician to have it signed, send it into the company. And then those supplies are then sent to the patient in the patient's home, and the patient actually brings those supplies in with them when they come per day.
Awesome, thank you. With your coding, how do you differentiate between primary tarda and lymphedema due to obesity in older patients?
So really that's going to basically come down to the physician there again to see whether that physician thinks that the lymphedema is not caused by the obesity or the or just older age, or if the physician thinks that everything else has been checked. All the testing has been run, whether that's from a cardiologist, a nephrologist, a vascular surgeon, all of those things, and everything else has come out quite clean from all of those testings. Now, obviously, if it's a significantly obese patient, normally we don't call that a Q80 2.0. But if we've got a normally statured patient or a more baseline statured patient, and all of those other things come back negative, then we're more inclined to think that it's probably a Q80 2.0, a primary lymphedema.
All right, thank you. If a patient has been sent for lymphedema treatment with an edema diagnosis or does not have lymphedema in their medical history, can we use the lymphedema ICD-10 code without a declared diagnosis from a medical professional first?
So this is what I do. I take my lymphedema orders and I rewrite them with the proper code on them. And then I ask the physician if they agree that this patient does have lymphedema in that extremity, will they please sign those orders? And I just explain myself. Sometimes I even type a little letter if I think it's a physician that I don't know very much, or sometimes it was somebody else filling it out for the physician and it was just a fluke anyway. So I usually send it back. We can't use that code unless the physician has used it.
I know we've talked about this a little bit, but just in case you have anything else to add, what wording do you use to support your maintenance patients with Medicare?
So I use like with those patients, I'm going to definitely use the fact that this patient now has had a large open wound, but the patient has had multiple bouts of cellulitis with frequent hospitalizations. Lymphedema has a high refill rate if left uncontrolled. Patient will now be placed on maintenance program to ensure that lymphedema does not creep up nice and slowly and cause recurrent cellulitis and issues with wounds. And then I'll set my goals that the patient won't increase more than so much percentage with him doing his normal daily activities and daily home maintenance program. Patient won't have cellulitis, that kind of thing.
All right, we're getting there. We've answered 35 so far. So we'll keep this to another minute or two here, and then we'll probably have to let Brandy get back to her patient caseload. Have things changed significantly with regards to not using petroleum-based products, or is it okay because you're taking it off immediately?
Pretty much I use a little bit of the petroleum base even with my hyperkeratosis patient. So just so long as we don't have any open wounds and we know that we're going to come back in a couple of days and take that bandage off, I will still use a little bit of the Aquaphor and mix it with more of my lotion. And use that from time to time, even on those very hyperkeratotic patients. But when I'm using it in large quantity like that, I'm coming back and taking it off. Yes.
Thank you. If a thickened area around the anterior thigh has been present for about 12 months, can this be reduced manually?
Depends on what it's created by. So it really depends on if this is from an area that maybe had a DVT in that region, had some sort of tumor formation around that area. It really kind of depends on what it was from, making sure that's not a lipoma per se, but more of a true thickening from lymphedema itself. So if it is a true lymphedema in that area, then yes, it can be reduced.
All right, we had a question in, where can I find more information on the Early Impressions program? So Esme, our junior product manager, has saved your information, and we will reach out to you with more information on that specifically for you to be able to see. So thank you for that. And I'm just going to quick check the chat box. I think there was a couple in there that were not put into the Q&A section. How do you bandage a large medial leg lobule?
Very carefully. Don't follow your traditional bandaging type patterns. That's a whole other lecture.
Yep. And then we had some questions on lymphedema, which we will have to pass this time due to time, as well as this lecture was not based on lymphedema. But I know Brandy has her information if you wanted to reach out to her.
Absolutely.
And a lot of thank yous and nice presentation, superb presentation. And we agree, Brandy, thank you so much. It was great to have you here today. Clearly so many great questions from the content that you presented with some incredible results. So we appreciate your time, and we appreciate all of you that attended. We will follow up with the recording so that you guys will have access to visit that at a later point if you wanted to take a look at that again. So thank you all, and we hope that you have a great rest of your day. And thank you very much, Brandy.
Thank you, Lindsay, and you all have a wonderful day. And thank you for your wonderful questions and being here today.